So to begin with, sir, we would like to know what is the incidence or the burden of angina in India, and what treatment options are available for managing the angina.
Yeah. Before I answer your question, thank you very much for calling me here and for the kind introduction. But one little modification.
Yeah.
You said he was the professor. I still am.
Okay.
And I am also still the interventional cardiologist at Ruby Hall.
Okay.
So instead of was, it is
Okay.
is.
Okay.
Very important question you asked. What is the load of angina? Angina is the chest pain caused by ischemia to the heart or myocardium. And though we don't have accurate data from the Indian subcontinent, but the prevalence has been rising from around 4%, I believe, in the 60s. Then it started going up to 6, 8, and presently around 10%. Have ischemic heart disease. Now that includes all forms, not just angina. It will include infarctions, it will include silent myocardial ischemia,
Right.
and arrhythmias due to ischemia to the heart. So all forms together, maybe around 8 to 10%, or it may have gone up by now. This is data for 3 or 4 years ago.
Okay. Okay, sir. So what are treatment options are available for managing angina patients?
See, the treatment options are, first of all, the medical management. And I think 3 groups of drugs have formed the mainstay. The beta blockers, including the newer beta blockers, then the calcium channel blockers, the nitrates. Then there are, the antiplatelet drugs, which are very often used, like aspirin and other drugs. And lipid-lowering drugs are also used for patients who have hypercholesterolemia or maybe metabolic syndrome. So these are the main groups of drugs. And when these drugs are not effective in controlling angina to a satisfactory level, then the patient undergoes angiography, coronary angiography, those suitable for angioplasty and for whom it is indicated, they undergo coronary angioplasty, and a smaller group, they go for coronary artery bypass surgery.
Right, sir.
So these are the traditional 3 modes or modalities of management of the angina patient.
Right, sir. So, sir, as you said, when the pharmacological treatment fails to improve the angina, then patient probably go for the interventional kind of treatment modality. So, there is an emerging terminology nowadays which is called as a no option angina. So, can you just elaborate on that and how to tackle such situation?
Yeah, it's a relatively a new term, and no options angina was my topic of the lecture which I delivered in the CSI Kochi here,
Okay.
2016. And no options angina actually means that when all the drug treatment has not controlled angina and the patient is not a suitable candidate for coronary angioplasty or bypass surgery, then it is called as a no options angina. Means you have exhausted all options.
Right.
There are no options available.
Right, sir.
And you have to find some way to manage these patients, which can be very challenging.
So, sir, for such kind of patients where the treatment, pharmacological treatment has failed and patient is not able to go for the interventions, then what are other treatment options you would like to recommend for such patients?
Yes, there are very good treatment options available. But the first thing I would like to remind I would like to remind myself and my colleagues who are managing such patients that have you really used all available drugs or medicines which have a good anti-anginal effect? And there are certain drugs like ranolazine,
Right, sir.
right? Like ivabradine. Then there is nicorandil. Yes. Then there is trimetazidine.
Right, sir.
Trimetazidine was discarded a few years back, but there is data which favors trimetazidine now. And then there is allopurinol. So these are the drugs which we don't commonly used for angina, like the earlier groups which I talked about, beta blockers, calcium blockers, and nitrates. But first we have to, before labeling the patient as no options angina or refractory angina, we have to just see whether we have used all these drugs or not.
Right, sir.
And then if we have not, we've used this and still the angina is not getting controlled, then it is really no options angina.
Right, sir.
Now, as you asked me, there are certain very interesting non-invasive and invasive techniques available. And I will begin with EECP,
Okay.
you know, the external counterpulsation. And in this, what is done is that there are cuffs applied to the patient's legs. Of course, the patient is first made to lie down comfortably on a bed, and these cuffs are applied
Okay.
to the leg, to the thighs, and there there is a very advanced level machine, and these cuffs are inflated and deflated. Now the inflation is in diastole,
Okay.
and the inflation is in a sequential manner. First the leg cuff, after 50 milliseconds the second, the lower thigh cuff, and after another 50 milliseconds the upper thigh cuff.
Okay.
And this is ECG controlled. So in diastole the cuffs are inflated, the venous return to the heart is increased, right, and the coronary filling improves,
Right.
because the coronary filling occurs in diastole.
Right, sir.
And in systole, all the three cuffs get deflated. So the afterload of the heart reduces, and the cardiac ejection fraction also improves.
Right.
And the follow-up data on with this kind of treatment, actually before I talk about follow-up, I must tell you that 35 sessions are generally recommended, 1 hour each, and if possible daily or with short intervals. And there is considerable improvement in angina. Canadian Cardiovascular Society grades, if you see, either improvement at least by 2 grades, improvement in exercise tolerance, improvement in nitrate tablet intake, and so on and so forth. And the very, very interesting point is, even after termination of this treatment, the benefit continues for a longer time.
Right.
It is not that for the rest of your life you have to go put your legs into the cuffs and get them inflated. No.
Right.
You take 35 sessions, and in one study, 5-year follow-up showed that 70% of patients still experience benefit.
Right, sir.
So this is one treatment. And the other interesting treatment is ESMR.
Okay.
Have you heard of ESMR?
No, sir.
No? A few weeks back, maybe even I had not heard about it.
Okay.
ESMR is extracorporeal shock wave myocardial revascularization.
Okay.
ESMR is the shortcut. Now here, actually what happens is, ultrasound shock waves are transmitted to certain spots in the heart. Now before you use this treatment, you have to show that there is a viable myocardium. It is useless to treat scar tissue with this. So there has to be viable myocardium which is ischemic.
Right, sir.
And second point is, we don't use this treatment in acute situations like acute myocardial infarction or acute coronary syndrome. Patient has angina, agreed, but it should not be a acute situation.
Right, sir.
And what is done here is that, 3 sessions per week, and then you may give a gap of 2 weeks, and again 3 sessions, again a gap, again 3 sessions, and up to 10 sessions can be given to the patients, or even more, depending, varying from case to case. And how this treatment works, it's very interesting. Around the cells of the heart, there are microbubbles, inside and outside the cells. And these ultrasound waves disrupt those bubbles.
Okay.
Those bubbles rupture. And there is a sort of, vibrations are created around the cells, and as a result of that, there are chemoattractants which are produced locally or attracted locally, such as nitric oxide.
Right, sir.
Then there are nitric oxide is a very well known substance,
Yeah.
and there are others which are attracted to that particular ischemic area,
Right.
and that is what makes the difference.
Okay.
Collaterals are increased. There can be neovascularization, that means new vessel formation can be there,
Sir.
so on and so forth.
Okay.
And again, just like I talked about EECP, that is the external counterpulsation, here also there is significant benefit in angina threshold, exercise tolerance, morbidity, and the benefit is quite significant, and it has been proved scientifically.
Right, sir.
So these are the two main non-invasive treatments I would like to talk about.
So, sir, thank you so much for your key insights on no options angina.
One more thing,
Yes, sir.
just in half a minute I would like to tell.
Please, sir. Please, sir.
There is an invasive treatment called coronary sinus reducer. There is a stent, hourglass shaped stent, which we put into the coronary sinus through the venous approach, and this creates a back pressure into the arterioles supplying the myocardium, and then again, because of this back pressure, there is increased formation of collaterals, new vessel formation, and again this has been found to be very useful. So this is a one invasive technique which has again been scientifically proved. There are other techniques like neuromodulation, etc., which just give pain relief, but they don't treat the ischemia. So these are the newer modalities which we should know about and which can be very useful in this group of patients.
Right, sir.
No options angina.
Right, sir. So, thank you so much, sir, for your time, sir. Thank you.
Thank you very much. Answer your question. Thank you very much for calling me here and for the kind introduction. But one little modification.
Yeah.
You said he was the